Imagine you're an emergency room nurse, right? A patient gets wheeled in after being pulled from a burning building.
Okay, setting the scene.
Yeah, and they're totally awake, they're talking to you, and their oxygen levels are sitting at like a perfect 97%. I feel like most people on the street would look at that and say, well, they're safe.
Oh, absolutely. They look fine on paper.
Right. But a trained trauma nurse spots just a smudge of soot on their nose and a small tender bruise on their side and immediately calls a level 1 life or death emergency.
Because the reality of emergency medicine isn't just about treating what's happening right in front of you. It's about treating what is going to happen in exactly 3 minutes.
Exactly. Welcome to today's deep dive, everyone. It is Sunday, April 5th, 2026. Today, we are cracking open this massive stack of real medical and nursing notes focused on high-stakes, worst-case scenarios.
Specifically, bioterrorism and trauma triage.
Right. And whether you are prepping for a medical career or you're just insanely curious about how hospitals function when the absolute worst happens, this deep dive is going to give you the ultimate insider's understanding. So, okay, let's unpack this.
The overarching theme in these source materials isn't about, running faster, yelling louder like you always see on TV shows.
Right, the dramatic screaming down the hallway.
Exactly. It's actually about a systematized response to chaos. Healthcare professionals take these unpredictable, terrifying moments, and they filter them through a strict, objective protocol. When the world falls apart, you don't rely on panic, you rely on the checklist.
And we are starting right at the extreme end of that checklist today with biological threats. The invisible monsters, basically. The source material outlines specific protocols for 3 heavy hitters, which are anthrax, botulism, and Ebola.
Let's start with anthrax.
Yeah, I was looking through the notes, and what surprised me is that it's not a one-size-fits-all infection. The danger really depends on how it actually breaches the body.
That entry point dictates everything. Like, if you are exposed through the skin, you develop cutaneous anthrax.
Which presents as those severe necrotic ulcers, right?
Yes. It's dangerous, but it's localized. Now, if it gets into your food, you're dealing with gastrointestinal anthrax, massive abdominal pain, nausea, severe diarrhea.
But the absolute worst-case scenario is inhalation.
Without a doubt.
Because that's the one that starts off looking like just a basic flu, a fever and a cough. But then it quickly snowballs into meningitis, systemic shock, and death.
And the notes highlight a really fascinating detail about the nursing care for anthrax here. It is not spread person to person.
Wait, really? So you can't catch it just by standing next to someone who inhaled it?
No, you can't. But the physical danger of the spores on a patient's clothing is immense. The sources use this brilliant analogy. Think of dumping baby powder on your shirt.
Oh, right. And when you pull that shirt off, the powder just poofs into the air. It aerosolizes.
Exactly. So if a healthcare worker is undressing an anthrax patient and isn't incredibly methodical about it, those microscopic spores on the fabric get launched right back into the air.
And then the nurse could inhale them.
Right. That is why strict decontamination, carefully removing and bagging those clothes, has to happen before you even begin the medical treatment.
And when you finally do get to that medical treatment, the protocol requires some really heavy-duty antibiotics. Drugs like erythromycin, gentamicin, ciprofloxacin, or doxycycline. But here is the kicker. The patient has to take these for 60 days. 2 full months.
It's a massive regimen.
It is. Why 60 days? Like, what actually happens if you stop at day 45?
Well, to understand that, you have to look at the biology of a spore. Anthrax spores aren't like normal bacteria. They are essentially microscopic seeds wrapped in a really tough armored shell.
So they're protected.
Very protected. They can lie completely dormant in your lungs for weeks before they decide to hatch, basically, and become active bacteria.
Oh, wow. And the antibiotics only kill the active bacteria.
Exactly. They do nothing to the dormant spores. So if you stop the medication on day 59, a dormant spore could activate on day 60, release its toxins, and kill you.
That is terrifying.
It requires immense patient education to ensure they don't stop taking the pills just because they feel better.
Right, because the threat is literally just sleeping inside them. Now, anthrax lurks in the environment, and so does our next agent, botulism. You usually hear about this with bulging canned goods or when someone gives honey to an infant.
Right, but as a bioweapon, it can be aerosolized or slipped into a food supply. And what's fascinating here is the specific mechanism of how botulinum toxin physically attacks the body.
It targets the nervous system, right?
Specifically the neuromuscular junction. Normally, your nerves send a chemical messenger called acetylcholine to tell your muscles to contract.
Okay.
Botulism acts like a bouncer at the door of the muscle. It completely blocks the acetylcholine from getting through. The muscle never gets the memo to move.
So that leads directly to the hallmark symptom described in the notes, which is symmetrical descending paralysis, meaning it literally starts at the top of your head, so your eyelids get droopy, your speech slurs, and then this paralysis moves down evenly on both sides of your body.
Until it hits your diaphragm.
Right, and your diaphragm is the muscle that pulls air into your lungs. Once that is paralyzed, you just stop breathing.
So the entire goal is to identify those droopy eyelids early and intervene before the paralysis reaches the chest.
The intervention sounds incredibly intense, though. The notes mention administering an equine antitoxin, which, I mean, that's derived from horse proteins?
Yes, it is.
And it neutralizes the toxin floating in the blood, stopping the paralysis from getting worse, though it can't reverse the damage already done, right?
Correct. It halts the progression.
But using a horse-derived serum seems like it would carry its own massive risks.
A huge risk, specifically anaphylactic shock. The human immune system often recognizes those horse proteins as a severe foreign threat and just launches a life-threatening allergic reaction.
Oh, man. So you're fixing one problem and causing another.
Potentially. Because of this, the protocol dictates that before a nurse even touches that antitoxin, they must have diphenhydramine and epinephrine physically drawn up and ready at the bedside.
That is wild. You are treating a deadly toxin with a cure that could trigger a deadly allergic reaction. You literally have to be ready to pivot in seconds.
You do. It's high-stakes medicine.
Yeah. Now, anthrax and botulism are terrifying because they use the environment against you. But our final biological threat, Ebola, shifts the danger entirely onto the patients themselves. With Ebola, the patient's own bodily fluids become the weapon.
It's a hemorrhagic fever.
Right. The source material describes it causing bleeding from everywhere: eyes, gums, internal organs. It even discolors the soft palate in the mouth, alongside causing liver dysfunction and hearing loss.
Because it's transmitted through direct contact with those fluids, the hospital precautions escalate to the highest possible tier. You need a negative pressure room, which continuously pulls air inwards so nothing escapes into the hallway.
And the gear they wear is next level. N95 masks, full-body impermeable personal protective equipment. The notes explicitly warn that donning and doffing, so putting on and taking off that PPE, is an arduous 20-minute process.
Taking it off incorrectly is just as dangerous as not wearing it at all.
Because the outside of the suit is covered in the virus.
Exactly. And clinically, caring for an Ebola patient demands incredible restraint. You are watching a patient actively bleed, so you obviously withhold anti-clotting drugs. But furthermore, you have to severely limit any procedure that breaks the skin.
Wait, really? So if they are losing fluids, you'd normally want to start an IV line right away. But you can't.
You might absolutely have to, but it's a terrifying risk-reward calculation. Every single time you puncture that patient's skin with an IV needle, you're creating a new, uncontrollable site for hemorrhage.
Oh, because the virus prevents the blood from clotting.
Right, so that tiny needle prick could just bleed endlessly.
It's staggering to think about the focus required to manage that. But dealing with a bioterror agent, or frankly any massive disaster like a building collapse or an interstate pileup, leads to another brutal complication, which is sheer human volume.
And when the hospital system is suddenly overwhelmed, the math of survival changes.
Right, and that introduces the logic of mass casualty triage.
Which is a profound shift in medical ethics, dictated purely by limited resources. Normally, emergency medicine follows a simple rule: treat the sickest person first.
Like a cardiac arrest takes priority over a broken arm.
Exactly. But in a mass casualty event in the field, the goal completely flips. You are now trying to do the most good for the most amount of people.
I call this battlefield calculus.
Yeah.
First responders use these color-coded triage tags. Green is for the walking wounded, so minor injuries.
Yeah.
Yellow means delayed treatment. Red means immediate life-saving care is needed.
And the triggers for a red tag are purely numerical.
Right, like a respiratory rate over 30 breaths a minute, capillary refill taking longer than 2 seconds, or the patient being unable to follow simple commands.
But the most sobering aspect of field triage is the black tag.
Yeah, this part of the notes was really heavy.
It designates a patient who is deceased or expectant, meaning their injuries are just too severe to survive with the resources at hand.
The protocol for this is brutally strict. If a patient isn't breathing, the responder does a basic manual adjustment, a head tilt, chin lift, to open the airway. And if the patient still doesn't take a breath on their own, the responder must put a black tag on them and literally walk away.
In any normal hospital setting, a pulseless, non-breathing patient means you immediately start CPR, push epinephrine, call a code blue.
But not in a mass casualty event.
No, because the time and physical exhaustion required for 2 responders to perform CPR on one patient means 3 other people with survivable injuries might bleed to death while waiting for help. You just cannot expend all your resources on a low-probability survival when others can definitely be saved.
If you're listening to this and wondering how anyone makes that call, you have to remember that triage is about managing the entire disaster, not just the person in front of you.
Well said.
But here's where it gets really interesting. Once those survivable patients are transported away from the field and actually enter the emergency department, the triage system changes entirely. We move to the Emergency Severity Index, or ESI.
Inside the hospital, we use this 1 to 5 scale to prioritize who gets a bed first, based on the acuity of their condition and the resources they will need.
Right. Level 1 requires immediate life-saving intervention. They skip the waiting room entirely.
Level 2 is a high-risk situation, like severe pain or danger zone vital signs.
Which the notes define as a heart rate over 100, respiratory rate over 20, or an oxygen saturation below 92%. All the way down to level 5, which requires 0 hospital resources, like someone walking in just to get their stitches removed.
The vital concept behind the ESI is that it is dynamic. A patient's condition is never static. They can deteriorate while sitting in the waiting room, which means their triage level has to shift.
Which brings us right back to the scenario we opened the show with. Our patient from the burning house. Their oxygen is fine, their breathing is normal. Why does a smudge of soot on the nose and a tender bruise on the flank make them jump to an ESI level 1?
Because the soot on the face suggests they inhaled superheated air or toxic chemicals. Their throat might feel fine now, but that delicate airway tissue is going to swell shut.
Oh, wow. And the bruising.
That tender flank bruising. The flank is your side, right over your kidneys. Bruising there is a classic indicator of internal bleeding into the retroperitoneal space.
So they have completely stable vital signs right now, but their abdomen is slowly filling with blood.
Exactly. In 3 minutes, they will lose their airway and crash into hypervolemic shock.
You're triaging the future. That makes so much sense. So let's say our patient makes it through the doors and is assigned a bed in the trauma bay. The medical team is swarming them. They need a foolproof way to assess this person without missing any of those hidden injuries.
This is where the primary and secondary surveys come in. The primary survey is an aggressive, systematic checklist designed strictly to find and fix immediate, life-threatening injuries. It uses the ABCDE acronym.
Okay, A is for airway, ensuring it's open. But the notes highlight a massive caveat for trauma, which is cervical spine stabilization. You don't want to violently tilt someone's head back to open their airway if they have a hidden broken neck.
Because you could completely sever their spinal cord, so they use C-collars and carefully log roll the patient.
Got it. B is for breathing. This involves auscultating, which means listening with a stethoscope, but you aren't just listening for a heartbeat.
No, you are listening for the absence of sound. If you hear breath on the left side of the chest, but total silence on the right, that lung has collapsed.
Makes sense. C is for circulation, checking central pulses like the carotid in the neck and the femoral in the groin. You don't bother with a flimsy wrist pulse yet.
Right, you check skin temperature and look for massive external hemorrhage.
Then D is for disability, which is a rapid neurological check using the Glasgow Coma Scale. Are their pupils reacting to light? Do they know what year it is?
And finally, E is for exposure. You have to cut off their clothes to see the injuries, but immediately cover them with warm blankets to prevent hyperthermia.
Because hypothermia actually stops blood from clotting properly.
Exactly. Now, there is a cardinal rule of the primary survey. It is strictly chronological.
Meaning you can't skip around.
Right. If you are on step C, checking circulation, and the patient suddenly stops breathing, you do not finish the rest of your checklist. You immediately stop, go back to B, and fix the breathing.
It's a rigid hierarchy. Airway kills you faster than bleeding. Bleeding kills you faster than a brain injury. You never complete the survey while the patient is dying from a skipped step.
Never.
Now, once they are stabilized and transferred out of the chaotic ER, maybe up to the med-surg floor, the ICU, the pace changes. We move to the secondary survey, which uses the acronym FGHI.
The immediate threat to life has been managed. Now, the goal is to get a comprehensive picture.
Right. F is for a full set of vital signs and focused adjuncts. Adjuncts meaning things like an NG tube, so a tube going down the nose into the stomach to pump out contents, or a Foley catheter inserted into the bladder to monitor exact urine output.
G is for give comfort, meaning you can finally focus on treating their pain.
H is history, and a complete head-to-toe assessment.
If we connect this to the bigger picture, the final step I hear, inspecting posterior surfaces is where many hidden traumas are finally caught.
Oh, because you're actually looking at their back.
Yes, unless there is a specific doctor's order keeping a patient flat because of a known spinal fracture, nurses must physically roll the patient and look at their back.
Because if you don't look at their back, you miss the flank bruising from our burning house scenario. You completely miss the internal bleeding,
Exactly.
which transitions perfectly into the specific, terrifying internal traumas the notes detail.
Thoracic and abdominal traumas are incredibly deceptive. The notes list great vessel disruption tearing the aorta and diaphragm tears, but one of the most mechanically terrifying is cardiac tamponade.
That's where blood fills the sac around the heart.
Exactly. The heart sits inside a tough fibrous sac called the pericardium. If a trauma causes the heart muscle to bleed, that blood fills the sac.
But the sac doesn't stretch, does it?
No, it doesn't stretch at all. So as more blood pours in, the pressure turns inward, literally crushing the heart until it physically cannot expand to pump blood to the body.
It's basically suffocating the heart. The notes also ask a really great trivia question. What is the most common cause of an airway obstruction in a trauma?
People always think it's a crushed windpipe.
Right, but it's not. It's the patient's own tongue falling back or knocked out teeth and vomit blocking the airway. The body's own structures become lethal weapons.
And the same principle applies to abdominal trauma. The peritoneal cavity in the pelvis can hold massive amounts of blood without a single drop ever spilling onto the floor.
Think of blunt force trauma from a steering wheel. The nurse might not see external bleeding, but the patient's abdomen is getting distended, rigid, and guarded.
That is why the nursing notes stress continuous monitoring of H and H labs, hemoglobin, and hematocrit. If those blood cell counts are dropping, the patient is bleeding out internally.
Now, the final major category of trauma covered in the sources is musculoskeletal. Generally, broken bones aren't immediately life-threatening, with two major exceptions: a pelvic fracture, which can shear major arteries, and traumatic amputations.
But there is one specific complication the notes focus heavily on, which is compartment syndrome.
Okay, let me make sure I have this analogy right. Say you break your forearm. Naturally, the broken tissue swells up, but that swelling is trapped underneath the fascia.
Right. The fascia is the tough, unyielding membrane that wraps around your muscle compartments. Think of it like a tight leather sleeve. It does not stretch.
So because the fascia won't stretch, the swelling pressure turns inward. It crushes the blood vessels against the bone, completely cutting off blood flow to your hand. It's basically your own body acting as an internal tourniquet.
That is the exact mechanism. The swelling has nowhere to go. If that internal pressure cuts off the arterial blood supply, the muscle tissue in the arm and hand will begin to die of starvation.
Wow.
That is why nurses obsessively check capillary refill, pulses, and sensation distal to the injury, meaning below the break down in the fingers.
If a nurse notices the patient's fingers are cold, pale, and pulseless, that is a drop-everything emergency. The healthcare provider has to surgically relieve that pressure, usually by slicing open the fascia to give the muscle room to swell out. Otherwise, the patient loses the limb.
The notes also mention other systemic complications from broken bones, like deep vein thrombosis, pulmonary embolisms, and fat emboli.
Wait, how does fat get into the bloodstream from broken bone?
The inside of your large bones, like your femur, is filled with fatty bone marrow. When that bone snaps, the trauma can actually force microscopic droplets of that fat into the ruptured blood vessel.
Oh,
Those fat droplets travel through the bloodstream until they get wedged in the tiny capillaries of the lungs, blocking oxygen exchange.
that is wild. Now, we really can't forget the late-stage complications of multiple traumas. The notes drop some heavy acronyms here: ARDs, SIRS, and MAUDIs. A patient might survive the initial car crash, they survive the emergency surgery, but days later they fall victim to MODA's multiple organ dysfunction syndrome. How does that actually happen?
It comes down to an immune system panic attack, essentially. When the body sustains massive tissue damage, it triggers a systemic inflammatory response that's SIRS. The body's own white blood cells, which are supposed to heal you, get overly aggressive and start attacking healthy tissue.
Oh, so it turns on itself.
Yes. It causes a deadly domino effect where the lungs fill with fluid, then the kidneys fail, then the liver shuts down. The initial shock waves of trauma can kill you long after the bleeding stops.
The fight for survival doesn't end when the primary survey is over.
Yeah.
So what does this all mean? We have traced a path from the microscopic biology of dormant anthrax spores requiring 60 days of antibiotics to the brutal battlefield math of mass casualty triage tags.
It's a lot to take in.
It is. We've seen the relentless, chronological ABCDE checklist that ensures a nurse doesn't miss a blocked airway while distracted by a broken leg. And we've uncovered how the body can trap itself with an internal tourniquet in compartment syndrome. Understanding this architecture of survival gives you a profound new lens on healthcare. It's not just about acting fast, it's about knowing exactly what to act on first.
This raises an important question, though. We've discussed the strict, uncompromising logic of mass casualty triage, the black tag protocol, where a responder must manually check an airway and then walk away from a patient who can't breathe in order to save 3 others who can.
Right.
But as medical technology relentlessly advances, extending what an immediate life-saving intervention actually looks like, you have to wonder, how will the ethical boundaries of these triage systems shift when the definition of saving a life is constantly being rewritten by machines?
That is a heavy, incredible thought to ponder. The math of survival is always changing. Thank you all for joining us on this deep dive into the very real, very structured world behind the emergency room doors. Until next time, stay curious and keep learning.